I welcome everyone. I would like, first of all, to thank the organizing committee for the kind invitation. It's my pleasure to be here with you today. So I was asked today to present something new, something nice in pediatric kidney transplantation. I thought discussing about the new drugs would be something interesting. However, I realized that we're not very, very far from where we were a few years ago, despite recent progress. So I added towards a more individualized medicine because at the end of my presentation, you will see that I try to explain how it is important to tailor our approach, both for initial and maintenance management, and avoid the one-size-fits-all protocol. So I was also asked to give a little bit of background. So my clinical experience in pediatric nephrology and transplantation is mainly within the two biggest London hospitals, and in which I have extensive experience in managing those pediatric patients before, during, and after kidney transplantation. I have been working in clinical research in non-invasive methods of kidney transplant monitoring, both in UCL London and now in my current work in Paris transplant group. I've been working in epidemiological big studies with the ERN ESPN registries, and I'm a member of various transplantation working groups, and I have no conflict of interest. So before starting and the gist of the presentation, I would like to give some key points about how important it is to discuss about this today. So as you all know, I suppose in this audience, kidney failure is a devastating condition in children and is associated with a 30-fold increased risk of mortality compared to healthy children. The prevalence of kidney failure is just increasing, basically, the ones needing kidney replacement therapy. And the numbers indicate that since 2009 in USA, we have an annual increase by 5%, whereas in Europe is around 2%. Among the different kidney replacement therapy modalities, thankfully, kidney transplantation and retransplantation also has been proven to significantly enhance both survival and quality of life in children compared to the ones remaining on dialysis. And then I put a last sentence about the costs, because I think it's quite significant to also mention that. So when a child has a kidney transplant allograft rejection, this costs about 72% increase on top of his routine cost, let's say, regarding kidney transplantation. Obviously, he or she has the risk of returning to dialysis. And if we take this annually, there was a health economic report by the IRIS group and his team that shows that this can cost up to $12 billion in healthcare annually, which is enormous. So my presentation outline will be presenting the immunosuppressions we have, what is the evidence, because I think it's important to talk about what is evidence and what is not. What trials do we have in pediatric kidney transplantation? Some results from non-randomized studies and different endpoints that we're using in our daily practice, despite the fact that there's not RCTs. What are the big studies in adults, without going into much detail on that, because there are too many. So I'm just going to mention the important ones. And then I will talk about how to individualize the immunosuppression selection based on risk stratification. So as we say in England, immunosuppression is a necessary evil, but at the same time a force for good. So the most common immunosuppressant regimens use a combination of agents with different modes of action to maximize efficacy and minimize the toxicities of those associated with its class of agent. In the next few slides, we're going to see the immunosuppression types, the timeline of their coming into the market, and their variability in use. So induction therapy. The immunosuppression types, they are divided in 4 categories. So we have the desensitization therapies, as we call them, bells and whistles. I'm not going to focus on that today because it's not the aim of this presentation. But I'm going to focus on induction therapies, which basically they're clearing the field. Maintenance therapies are tricking the body, there's nothing is going on, whereas it does. And on a little bit, I will touch on rejection therapies, because each one of those could be a different presentation, to be honest with you. So here you can see the timeline of immunosuppression therapies and when they entered the market. And of course, as you can see and you're aware of, there have been tremendous developments in transplant immunology and immunosuppression to produce all these drugs. From the first transplant in 1954 to the present era of transplantation. Azathioprine, I would like just to mention a few bits. So azathioprine was the first non-steroid immunosuppressant agent, which was used in organ transplantation. And this has been used for more than 50 years now. In 1980s, cyclosporine it was the first CNI to be introduced, followed by tacrolimus some years later. The new antimetabolites, MMF and mycophenolate sodium, which basically some of you might know it as Mifordic, which basically has directly the active MPA and it's better tolerated GI-wise. They're inhibitors that have mainly replaced azathioprine in most of the European centers as the drug of choice. The mTOR inhibitors, sirolimus and everolimus, have been developed as alternative antiproliferative drugs with antiviral potency. And belatacept was the first co-stimulation inhibitor against CD28, which has been now in use for roughly like 10 years. By mentioning this, I would like to say that the current induction therapy nowadays consists of basileximab, a monoclonal, which is a monoclonal anti-L2 inhibitor antibody. Some centers use alemtuzumab, which is developed around here before 2010. Which is a monoclonal CD52 antibody, and some centers, especially in high-risk patients, as we will see later on, they use antithymocyte globulin ATGs. All these changes, so if we follow the red bits with the numbers showing the graft survival at 1 year, have shown how impressive the improvement in graft survival has been since the new development of all these new agents. So we are currently, since 2020, we're currently talking for graft survival levels at 1 year more than 90%. I would say from the epidemiological studies, I'm doing even more than 95 to 97%, and a patient survival at around 90% at 1 year. But what is the immunosuppressant variability within the European centers? So as you might know, there is the CERTAN registry, which stands for Cooperative European Paediatric Renal Transplant Initiative. And within the last year, different protocols combining some of these agents have been used in pediatric kidney transplantation, with changes basically, as you see, in the various regimens over time. And there is also large variability between centers and even, of course, between countries. Changes in immunosuppressive protocols used in European countries reported to the CERTAN has shown, and so in these figures you can see basically what's happening the last 10 years. I downloaded it a few months ago. The main induction therapy was basileximab, which is used approximately in 50% of the patients in all the European centers included in this registry, with the majority of the centers using as maintenance a tacrolimus, MMF, and corticosteroid combined regimen. That was before the publication of the TWIST study, the TWIST protocol. So currently, which I will talk about it in more detail later on. So since the TWIST protocol, many centers, they do early withdrawal of steroids, like for example, we do in the UK, but some centers, they do keep it for a long time. I'm not showing it here, but the USA data is roughly the same. However, for induction, in many centers, they do use ATG much more than we do in Europe, even for low and middle risk patients. So here's again the combination regimen that I talked to you before, and that the majority of the centers are using that, even at the time of transplantation and also at 1 year post-transplantation. And here we're talking about more than 80, at that time point was 88 participating centers from 25 countries. But what is the evidence for what is happening and the trends we're seeing in the registries? So I have divided here with little comics influence from my son. We need in the most common use regimen, which is the 3 drugs. We always use the backbone agent, which is a CNI based protocol. Tacrolimus most of the times, or cyclosporin in some centers still. We have the adjunctive agent, which is our antiproliferative, and as I'm calling it, fight or flight agent, based on which center you're working, which is the steroids. But let's see the evidence in that. So taking the evidence pyramid into account, initial decisions about how to choose the right immunosuppressive agent should focus primarily on randomized controlled trials. So in 2002, there was this study from Trompeter and al. And colleagues that they published the first landmark immunosuppression trial comparing different immunosuppressive regimens, basically cyclosporin versus and steroids versus tacrolimus and steroids. And in the figure A, you can see in the figure 1, in A, you can see the patients, and then here the graft survival at 1 year. Although there was a trend towards better graft survival in patients who were randomized to tacrolimus, this unfortunately did not reach statistical significance. Then the authors found that the patients treated with tacrolimus had better graft survival and experienced fewer acute rejections in the first year after transplantation. In this trial, cyclosporin A dosing was quite low, and so as such, I would say that transferability to real practice in real life is quite difficult, also because triple immunosuppression with an antiproliferative nowadays, we don't use much cyclosporin. But for the centers that they do use, it's a trial that they need to take under account. So in the next study from Kranzberg et al., it was a prospective trial of maintenance immunosuppression in pediatric transplantation, and that was published back in 2007. So they compared cyclosporin withdrawal with MMF withdrawal after 1 year. And they had obviously 2 small groups of patients who were previously on the triple regimen, so cyclosporin, MMF, prednisolone. And although the glomerular filtration rate, as you can see, improved in the cyclosporin withdrawal group, 2 patients in this group experienced really severe antibody-mediated rejection, leading the authors to conclude that while cyclosporin A withdrawal has short-term benefits for kidney function compared to continue with this treatment, it is not without risk of complications. However, it is currently known that CNI-free regimens lead to a higher number of patients with acute and chronic humoral rejection. So again, this study cannot contribute to the debate about modern immunosuppressive protocols and if we should withdraw or not the CNIs. So let's go more in depth into trials in pediatric kidney transplantation, and starting with induction therapy. So induction therapy, as you all know in this audience, aims to deplete or modify the T cells before the donor antigen comes in. And induction agents include the ATGs and anti-CD52 antibody, and also non-depleting antibodies like the AL2 reception antagonist monoclonal antibody. According to the annual report in the USA of CRTR, roughly 60% of the pediatric kidney transplant recipients since 2018 receive T-cell depleting antibodies. 35% receive anti-L2 receptor antibodies, and 5% receive not at all induction therapy, which this is very weird for the European population, I would say, at least the centers I'm aware of. In 2009, GDIGO designated some immunological risk factors on which people should be based and decide accordingly on their induction therapy. And this included the age of the recipient, the HLA mismatch, the race, PRAs, cold ischemia time, AB on compatibility, etc., and delayed graft function. Now, in pediatrics, when it comes to pediatrics, in 2005, Benfield et al. Compared two induction regimens, murimumab, which is an OKT-CD3 inhibitor, and intravenous cyclosporine A, as you can see. So they had roughly 190 and 140 patients in each arm. This study did not reach significance at the end of the surveillance. However, personally, I don't know any center who is using murimumab. So again, it's not a study that I could use for my patients and creating my protocols. It cannot be applied today. In 2008 now, Offner and al., they took 192 patients. They divide them into the group of basiliximab versus placebo, roughly the same number of patients. And all these patients, they had also cyclosporine, MMF, and steroids as maintenance. Their population was an immunologically low-risk population, and this study showed a numerical but not significant decrease in the number of acute rejection episodes in the basiliximab group. And the authors therefore concluded that no significant difference could be shown between the groups. And interestingly, this trial, when we look at the registry studies, led to a significant reduction of use of basiliximab in the years following that study, mainly in Europe. Similarly, some studies like this one have been performed in adults, and there is currently a discussion on whether there really a role for AL2 inhibition during induction or not. Again, in most of the centers I have been working, we do use it very, very frequently. I would be interested to see if you're working in any centers that you're not using. There's a scarcity of RCDs on induction therapy in adult transplantation. So opinions conclude to differ on the value of basiliximab based on where you work, basically. Then about the belatacept, I've put it here, but I'm going to talk a little bit further down. Maybe let's give you a brief introduction. So belatacept was a big study in New England Journal of Medicine in 2016, and there were 660 patients, adult patients, that they were randomly assigned to a more intensive belatacept regimen versus a less intensive one, or a cyclosporine regimen. And 7 years after transplantation, the patient and the graft survivals, even the mean eGFR, were significantly better with belatacept than with cyclosporine. But I'm going to touch base with that a little bit more in depth later on. So regarding steroids now, one of our treasures or biggest problems in pediatric population. So we had an important study from Hawker and al. Back in 2010, that they proved that discontinuing steroids late, around 12 to 24 months after transplantation, if you have a stable patient, is safe, and it leads to improved growth and cardiovascular risk. And then later on, we have in 2010 the very important TWIST study, in which most of the centers are based nowadays when they do early withdrawal of the steroids, in which they used they studied 200 patients. They had the TAC MMF and late steroid protocol, and then they have the early withdrawal protocol versus skipping steroids for longer on. And as you can see in their figure here, they found that when you withdraw steroids earlier, basically this leads to better growth and has similar efficacy as steroid-based immunosuppressive regimens. Interestingly, the patients in the control arm received markedly higher doses of prednisolone than reported in other multi-center studies. As a result, it was probably easier to show a difference in growth patterns in the steroid-free versus steroid-on patients. But it's also interesting to know that the hypothesis was proven, and the intervention group protocol was not adopted as standard in more centers. In UK, that I was working until recently, we have adapted in most of our patients since the harmonization. But still in Europe, I can see many centers that they keep having steroids until long term. So there are two meta-analyses since those studies that they have included children. Haller and all focused on adults, on their cohort analysis, but they have some adolescents, and they came to the conclusion that the effect of steroid withdrawal in children is kind of unclear because of the decreased number of patients they had, of course. And then this one from Zhang and al. Evaluated the effect of steroid avoidance or withdrawal of meta-analysis by using 5 RCTs. They demonstrated the below point that I have put here. So there was an increase in delta height SDS, and that was present at the first year, even if there was no significant difference thereafter. The benefit was only seen in prepubertal patients, so this is something important to know for patients. There was no significance in delta height when completing avoidance was compared with early or late withdrawal. There was no significant difference in the acute rejection episodes. When there was late withdrawal, there was low risk of rejection. And there was no different engraft function between the two groups, which this is also very important to know. But steroid withdrawal was associated with a lower incidence of post-kidney transplantation, diabetes mellitus, and arterial hypertension. So this again, for example, if we have a patient pre-transplant who has a family history of diabetes, or he is pro-diabetic, or he is very hypertensive with resistant hypertension, it makes as clinicians to want to follow a steroid-free protocol afterwards, isn't it? What about, so there are clinicians that are afraid of PTLD, and they discussed the purpose of keeping with steroids and, of course, the myth in the long term when we have a risk of PTLD. So, as I told you, usually in low risk prepubertal Caucasian patients, many transplant centers physicians would prefer steroid-free or steroid withdrawal protocols. This is not only because of the studies I just showed you, but also because of this study published by Benfield and colleagues. And this study focused on an unacceptable high number of patients with post-transplant lymphoproliferative disease following treatment with a steroid-free immunosuppressive regimen comprising full-dose CNI and sirolimus. So PTLD was mainly, of course, is mainly seen with, Epstein-Barr naive young children. But at the time when the trial was conducted, the routine regular surveillance of EBV was not in practice. And indeed, it's various in different centers, the surveillance, time points. So anyway, this immunosuppressive combination was therefore rated as over immunosuppression. And since then, clinicians taking under consideration that to avoid the PTLD risk. What about mTOR inhibitors now? So sirolimus was used as the mTOR inhibitor in the trial conducted by again the group of Tornfeld-Burkhardt et al. And as you can see here, they studied for 3 years the outcomes of patients who were on this medication. It's the CRUDL study, the famous CRUDL study, in de novo pediatric kidney transplant recipients. In the last few years, I would like to say that even if everolimus has been mostly used as an mTOR inhibitor, it has not been studied in pediatric transplantation as sirolimus. Consequently, it's very difficult to draw any conclusions on the use of sirolimus or to establish whether sirolimus could replace the newer agent should everolimus not be available. In the CRUDL study, 9 months after transplantation has been conducted, The patients were randomized to a group receiving the standard treatment with steroids and a group receiving full dose of tacrolimus and MMF versus the interventional group treated with low dose TAC and everolimus. And in this group, they withdrew steroids. Plan was around 5 to 6 months after transplantation. The authors found that, in fact, 22% of the patients were still on steroids at 9 months after treatment initiation. And the majority, more than 90%, were only off steroids at month 12. 1 year data showed no difference in efficacy parameters between the group receiving the standard treatment and the one receiving tacrolimus and MMF. But there were some differences in side effects between those groups. And the intervention group, as well as had a higher discontinuation rate in the later group. Data from 3 years within the same study that they were published not back far ago, showed that the group that had everolimus and tacrolimus regimen and early steroid withdrawal provided comparable efficacy, renal function, and safety without affecting pubertal development in this population. And that's why sometimes, for example, when we have significant CNI toxicity in our protocol or whatever indication biopsies, many clinicians decide to switch in this protocol because exactly of the safety data that the 3-year CRADL study provided with us. So here I'm just doing a summary of the RCTs in the pediatric kidney transplant population. So basically, it has been shown clearly that the tacrolimus was better than cyclosporin A. Steroid-free protocols are feasible, especially in low immunological risk Caucasian patients if there is no over immunosuppression. Induction therapy with IL-2 inhibitor might not be advantageous in a standard risk population, even if most of us are using it. And regarding mTOR inhibitors, they represent an alternative, a good one, a good option that enables withdrawal of steroids as well as reduction of CNI when we need it. So now I'm mentioning some non-randomized studies that they bring important results in our field, and they are helping us. They're not sufficient, maybe, to make to base our decision making on the right choice of immunosuppressive regimens, as you know, there are no prospective randomized trials. But they're important for processing what to do during our methodology when we treat these patients. So these studies have shown that MMF can reduce the acute rejection and reverse the GFR loss when used as adjunctive therapy. Whereas these more recent studies have shown that everolimus has some efficacy with MMF, but different side effects. It can give less viral infections, but it has higher percentages of hypertension and cholesterol, and that was children. And then the depleting antibody alemtuzumab, I'm not sure if in your centers in Europe you're using it, but is quite frequent in some centers in the United States. It is used mainly for highly sensitized children and in low risk living donation kidney transplantation, and they have quite reasonable long-term results with this drug. Obviously, I think that experience with the drug is of ultimate importance. So if in a center you have not used it before, it's maybe difficult to trust what is going on. But if you have experience with the drug, you feel very comfortable with your own results. So why not? There was a paper in the United States in 2016 on paired kidney analysis. They compared roughly 3,000 deceased donor kidney transplantations performed between 2003 and 2013. And they treated with either with thymoglobulin or alemtuzumab. And they showed that after performing more than like 50 transplants with alemtuzumab induction, they had better outcomes compared to thymoglobulin. So some of the centers in the USA, they're very strong advocates about that drug. Another option for obtaining evidence for correct practice in pediatrics is, of course, to use data from large studies in adults. And although the physiology of children is clearly different to that of adults, adult studies frequently help to inform the direction of future research in our pediatric population. So here I'm putting two main really important studies in adults. In this one, from Ekberg and al., they have studied the reduced exposure to calcineurin inhibitors in renal transplantation. They used 1,645 patients. They followed up for 12 months, and they had really good results by low-dose tacrolimus and MMF, which was better than low-dose cyclosporin or sirolimus and MMF. And here, the study that we spoke about before, which has mainly adult patients, and it has shown that there was 43% reduction in the risk of death or graft loss in patients using belatacept at 7 years follow-up. However, we reached the point that we need to decide what we're going to do, because there's like not too much real strong and solid evidence in pediatric transplantation. We have to be based in some important studies from some of our colleagues in Europe and internationally, obviously in some adult studies. And here it comes the fact that the more clinically experienced has someone with a pediatric kidney transplant recipients, the more we feel that we need to stratify these patients. There was a real nice review from Lars Papp recently in Paediatric Nephrology, which I'm strongly recommending you to read. And basically, he is suggesting to divide the patients in low and high risk, low, standard, of course, and high risk, and then discuss about the induction therapy, steroid therapy, and the maintenance therapy based on the risk. So there are comments, I would say, because not all centers follow the same lines, about not having at all any induction therapy in low immunological risk patients, especially the ones who are having steroids. But as I told you before, I've not seen any centers doing that, so it would be interesting to know your practice. Then in low immunological risk patients, and standard immunological risk patients also. IL-2 inhibition as induction is a standard of considered as a safe and effective standard of care, and then the clinicians can decide if they want to use a steroid-free protocol or not. Based on the data I saw you, it seems a reasonable choice, especially in prepubertal Caucasian patients. And then when we have, on the other hand, high immunological risk patients, we should think of continuing steroid therapy or reinitiating it if we have removed it early, for example. And obviously, when we have high immunological risk patients, we need to increase all our immunosuppressions, basically, and be more targeted on exactly what's going on based on our biopsies, etc. If we have specific viruses, then, for example, if we have a patient with CMV, IgD, but is negative patient, then we can have, we could choose a low-dose tacrolimus regimen or cyclosporin for the centers that are using that, plus everolimus. When we have a patient with risk for BK viremia, a good choice would be to change to go to cyclosporin A and MMF. And when we have non-adherence adolescents, which is very, very frequent, go to belatacept is a good option. It was a recent study as well from a French group in adults that showed in CJSN that showed really good results in the long term in patients that they had to switch them from CNI. And basically it's because you can monitor them and know when they're taking the drug, that's all. So in conclusion, my conclusion, and I hope I won't disappoint you, is that we have very, very few randomized controlled trials in children. The large experience comes from the adult trials. I think that the local experience counts a lot. So if we have experience, with one drug and it works really well in the population, it's worth respecting that, and also provide our data so that we can discuss on national, international level what's happening, compare the data with other centers, and see if it's true or, local effects sometimes. Each center has its own best protocols. I'm not going to convince you what is my best protocol, but it would be good, however, to audit every now and then what the center is doing in terms of outcomes. For example, I'll give you an example. So in the UK, that we're using the twist with steroid minimization protocol and early withdrawal within 5 days. There's a suspicion that maybe with high MEF, especially in young children, we have more infections. And then we need to go to azathioprine and back to steroids. So sometimes, we don't fully follow finally this steroid minimization protocol because of this specific subpopulation within our cohorts. So now the centers are going to audit that and see, what is happening. And I think this is really important for best practice. And then last but not least, new artificial intelligence tools are expanding in the landscape. Very recently, the iBox was validated in children. And hopefully with more biomarkers integrated and machine learning tools, we will be able to stratify our patients by risk and adjust their immunosuppressive drugs accordingly. I was asked to make a slide about call to action. So I think that is absolutely necessary to include our patients in large HSCTs. So we have to put pressure either on adult colleagues or on our local authorities, collaborate to make protocols with other teams and just include them. Otherwise, it's very difficult to make solid conclusions. Until then, my personal opinion is that we should stratify the risk of our patients and have specific protocols per center for low, middle, and high risk patients. And then when there's a question that I have done it in the past, and I think it's really useful, is collaborate, find your colleagues and ask, what we are doing. At a point, we had a problem in getting basiliximab in the UK for a few weeks. So I reached out colleagues, in the abroad, and I found out about alemtuzumab more information and what else we could provide to our low and sudden risk patients. So I think it's important to have an international discussion when needed. I would like to thank you for your attention.